in this webinar. He's going to be joined by Dr. John Onentia as a co-panelist. Dr. Onentia is the PMTCT Program Manager at NASCOP. As usual, I encourage you to please use the Q&A for all your questions. Don't use the chat, only use the Q&A for us to keep track of your questions. So any questions that you have, please use the Q&A section. Thank you and welcome. My name is Dr. Bosire Rose and I will be your moderator for today. Let's go ahead and welcome Dr. Kinuthia to get started.
Thank you, Rose. Let me share my screen. Give me half a second. Okay, good afternoon, everyone. I hope you can see my screen.
Dr. Kinuthia, your sound is really, really low. We can hardly hear you. Okay. Kindly adjust your volume.
Okay, give me half a second. I just changed my computer. This one seems to be having a bit of a challenge.
It's barely a whisper.
Okay. I hope you can hear me now.
You are still very faint, very distant.
Is this better now?
Yes, it's a little bit better. Yes, it could be better if you can up the volume just slightly. That would be great, but at least it's much better.
Okay, thank you. Let me adjust. Okay, I believe now you can hear me.
Yes.
Okay. Okay. And you can see my slides.
Not yet. We can. It's blank. We can't see the slide. Earlier we could, but now we can't.
Okay. WHO, among others, to build on the momentum that had been building up towards elimination of new HIV infection among children, and came up with this framework called Start Free, Stay Free, and AIDS Free. And what Start Free stands for is here we are thinking of implementation of PMTCT interventions so that we eliminate new HIV infection among children 0 to 14 years. And the target here was that by 2018, the number would be reduced to about 40,000 and reduced to about 20,000 by the year 2020. And this was going to be achieved by reaching and sustaining antiretroviral drugs among pregnant women, so that over 95% of women would be receiving ARVs by 2018. Now, stay free is where we are saying the child, the adolescent girl, or the woman is kept HIV free through the currently available prevention intervention. And AIDS free means that where this individual has acquired HIV, then they are identified promptly and initiated on treatment promptly so that they remain AIDS free. So in terms of elimination of mother-to-child transmission of HIV, the first country to be validated was Cuba, and that was in 2015. And they received WHO validation for elimination of mother-to-child transmission of HIV and also syphilis. In 2016, Belarus and Thailand followed. In 2018, Malaysia. In 2019, Maldives and Sri Lanka. And you can see the countries where validation was done in 2017. And of note, if you look at all these countries, none of them are in Africa or in sub-Saharan Africa, which is the region we know bears the burden of HIV globally, where more than 70% of individuals living with HIV are in these regions. So what does a country need to do to receive WHO validation for elimination? And there is a criteria set out, and it requires that 95% of pregnant women should receive antenatal care, 95% of women should have HIV and syphilis testing during pregnancy, and 95% of those who are identified as either living with HIV or have syphilis would be put on treatment. And the minimum EMTCT impact targets are that you have less than 50 pediatric HIV cases per 100 live births, less than 50 cases of congenital syphilis per 100 live births, and a mother-to-child transmission rate of 5%, less than 5% in breastfeeding population, which means that out of 100 exposed infants who are breastfed, less than 5 acquire HIV. So how do we achieve that? And basically, this is employing the 4 prongs of PMTCT, which are primary prevention of HIV in women, prevention of unintended pregnancies among those who are infected, and the prevention of mother-to-child transmission by here mainly provision of antiretroviral drugs. And lastly, provision of care and support for HIV-infected mothers, their infants, partners, and families. So where are we? As of 2019, there were 140,000 new HIV infections among children 0 to 14. And we must celebrate that this is a success, because if you look at the graph, we had over 300,000, about 350,000 in the year 2000. And this number has reduced by 2019 to where we are talking of about 140,000. But we must also keep in mind that our target for 2020 is to have less than 20,000 cases. So definitely there is a lot of work that needs to be done to move from about 140, and we are in the year 2020, to move from 140,000 new infections in 2019 to 20,000 new infection in 2020. However, we know that there are interventions, they exist, and we know most of the infections are avoidable if these interventions are taken up and used optimally. If we are to look at our Kenya and focus in Kenya, we find there has been some reduction from about 9,000 cases in 2015 to just about 7,000 cases in 2019. That is a reduction, but that is not, it still falls short of the numbers we need to be, or where we need to be by 2020. You can see there is a bit of a gap that requires to be covered for us to reach that target. So looking at the Kenya generally, in total, and this is data from the KENFIA, the Kenya Population HIV Impact Assessment, we find that overall, the HIV prevalence in the country is 4.9, but it differs. It is higher in women at 6.6% and 3.1% among men. And here we have highlighted the 4 counties with the highest HIV prevalence. And we can see Siaya has a HIV prevalence of 15.3, Kisumu 17.5, Homa Bay 19.6, and Migori 13%. You can see the distribution in the rest of the country. So if we look at HIV prevalence compared between men and women, when we are just looking at the reproductive age women, we find that the HIV prevalence among women in the reproductive age is actually much higher than the prevalence among men for the same age. You can see the 2 bar graphs. The lighter one is for women, and the darker green is for men. This is again data from the from KENFIA, and what it shows is that as per that assessment, 97.3% of women were attending antenatal care. That is against a target of the EMTCT target of 95%, and 96% of the women received testing. However, even though we have women attending antenatal care, we find that majority of women attend first ANC in the 3rd trimester. They don't come earlier, which means there is missed opportunity for intervention to identify women who may be infected and putting them on antiretroviral drugs. The median point at which women start antenatal care is about 26 weeks. Then we find that few attend the minimum recommended 4 visits. And another challenge is that not all women are retested, which means that if the women acquire HIV subsequent to the first testing, they are not identified. Now, HIV and syphilis testing are conducted routinely as part of care, but we find that other STIs are currently not routinely tested, and we depend on syndromic management to identify women who have STIs and initiate them on treatment. The challenge is we know that syndromic management has very low sensitivity, which means that a lot of women who would benefit from treatment actually miss that opportunity. We may be happy with the data from Kenfia, but I think this data is just to show you some calls for wake up, that it's possible that maybe our numbers are not as rosy. And these are based on some projection from program data, where there is a concern that we probably could be having quite a substantial proportion of women who don't necessarily come to the clinics, and therefore they are unreached, which means that the way we think we are in progress towards our target, we probably have a lot more work to do. Now, why is it so important to test for STIs? As we mentioned a slide back, we want to illustrate this using this data from a study which we conducted from KNH in collaboration with our partners from University of Washington. And this one, we were following up women who are HIV negative. We enrolled them during pregnancy and followed them through pregnancy until 9 months postpartum. One, we found a high incidence of HIV of 2.3%, which is quite high. That is almost as high as what you see in other traditionally high-risk groups, like individuals in serodiscordant couples and female sex workers. But we also found a very high prevalence of sexually transmitted infections and genital tract infections. We can see that in this study, we had a prevalence for yeast of 25%, bacterial vaginosis 23%, syphilis 1%, gonorrhea 3%, chlamydia 6%, and trichomonas 6%. And looking at the cofactors for incidence, we find the key role that these STIs and genital tract infections play. You can see from these hazard ratios that they are quite high. 9-fold with syphilis, 4-fold with chlamydia, bacterial vaginosis, almost 3-fold, yeast 3, and any history of STI, 3-fold increase. So what has been our MTCT rate in the country? And here we are seeing a graph from 2012 to 2019. And we can see that we were at 16%. That is 16 in 100 exposed infants were infected, rose to 17% in 2014. Then we had a reduction to 8.3%, and that was sustained in 2016. However, in 2017, we had a rise. You remember what happened in 2017? We had the health workers industrial action. We also had the election with a lot of disruption in activities. And we can see that this led to an increase in MTCT rates. And again, in 2014, we were still at high. We were still at 12.4. The results for 2019 give a rate of 10.8%, which is still substantially higher than what we would want. Remember, we talked of an MTCT rate of less than 5% in breastfeeding population. So looking again at the program data, where do these infections, what are the source of these new MTCT infections? This is based on data from 2019. And we can see that in 23% of the cases, the mother got infected either during breastfeeding or it got infected during pregnancy, which means that these are women who at first ANC were negative, but subsequently seroconverted. As you can see, that means that new infections during this period are contributing to about 23% of MTCT. Then the next group were women who did not receive ARTs. during breastfeeding 5%, or during pregnancy 10%. Then we have a large group of women, 24%, who dropped out of ART during breastfeeding, and 23% who dropped out of using ART during pregnancy. So we can see failure to use, or dropping out of using ART is contributing to almost half of the new infections. So this data is based on 2019, and of the estimated 1.7 million pregnancy, it was estimated that almost 63,000 were births to HIV positive women. And out of those, just over 59,000, which is about 94%, received antiretroviral drugs. And by 8 weeks, only 67.3%, 2/3, had been tested, which means that the HIV status of the other third of infant was unknown. And we have 10.8% of the infants infected, and keeping in mind that our target is less than 5%. So again, this is data from the Kenfia, and they interviewed women and found that out of 100 women, 92.4% reported that they, the women who had delivered in the previous year, 92.4% reported they were HIV negative, 3.6% reported they were HIV positive, and 4% were not tested. Their status was unknown. And among the women who are HIV positive, 92.1% were using antiretroviral drugs. Just shows that there is still a bit of a gap that needs to be met, so that we have 95% of the women receiving ART drugs. Dr. Jonah Onentia will be talking more about optimizing the new regimen, because the country now is moving to having all women on TDF, 3TC, and DTG. So I'll leave that for Dr. Onentia to make a comment and give the current position. So antiretroviral drug use has been rising steadily, but not up to where we are. We can see there is some slight increase if you look at from 2015 to 2019. However, even when we say over 90% of women are using ARV drugs, it's also good to look a bit deeper and see, do these women use all the drugs at all the time points? Remember, transmission of HIV to the infant can occur during pregnancy, it can occur during delivery, and it can occur after delivery. And in this evaluation of PMTCT services, which was conducted in collaboration between NASCOP and KEMRI and the CDC, we found that actually 73% of women used ART during pregnancy, 68% used during delivery, 64.9% or 65% used in the postpartum. But if you look at overall, women who used ART in all time points, it was 60.4%, which means 2 in 5 women did not use antiretroviral drugs at all the time points. And even at that time, we still had quite a huge drop-off. We can see that about 24% of women reported that they discontinued drugs after delivery, which is a substantial number. And that is almost similar to what we saw when we looked at what were the factors which may have contributed to the new infant infections. So how do you support women to retain or continue using ART? This is another study conducted by Kenyatta National Hospital in collaboration with the investigators from University of Washington. And here we were evaluating AIM health strategies to optimize adherence and efficacy of option B plus PMTCT. And this was an unblinded 3-arm randomized clinical trial. So we had women in the control arm who received the standard of care. Then we had another group of women in the one-way arm who received one-way text messages. And we had the third group of women who received a two-way message, which means they would get messages and they would be able to respond either to a prompt or to an area of concern. We enrolled 825 women, and these women were enrolled during pregnancy and followed up to 2 years postpartum. For the women in the interventional arms, they received weekly semi-automated motivational and educational SMS and visit reminders. And they had prompts to which they could respond. We had follow-ups at 6 weeks, 6 months, 12 months, 18, and 24 months postpartum. And the outcomes we'll be looking for will be virological failure, maternal retention in care, infant HIV infection or death, antiretroviral drug resistance, and adherence. We have already completed follow-up of the women, and now we're in the process of data analysis. So this is results will be available soon. The next important component of PMTCT is preventing unintended pregnancy. And we know we have high unmet need for family planning, and it's currently estimated at around 27%. NASCOP now has come up with a tool to assist providers perform pregnancy intention assessment among women of reproductive age. And this will allow that those women who do not desire pregnancy can be offered contraception or can be counseled for contraception, and to work with those women who desire pregnancy to ensure that they have achieved viral suppression before they get pregnant. This will ensure that we are providing optimal care to the woman irrespective of what her pregnancy intention desires. And this is important because, again, looking at this data, which is from the Kenya AIDS Indicator Survey 2012, we find that quite a large proportion of women who attend comprehensive care clinics or who are receiving HIV care may not probably be desiring pregnancy. But what you find of concern is that you have almost 2 in 5 women not being on contraception, which means they are at risk for unintended pregnancies. So what contraception do women use? And this is a cross-sectional study, which again was conducted in collaboration with the CDC, KEMRI, and NASCOP. And here we were looking at among other things, we looked at frequency of contraception use. And what we found is that if you look at the use of a long-acting reversible contraception, is quite low. 12% among HIV-positive women and 15% among HIV-negative women. When we look at injectable, 33% for the HIV-positive women and 43%. And when we go to effective contraception, again, we find that there is a lower prevalence of contraception use among women living with HIV at 57%. So one of the most important intervention for elimination of mother-to-child transmission, besides providing antiretroviral drugs to those women who are already identified as infected, is primary prevention, so that those women who test negative are supported to remain HIV uninfected. And from the data which we just shown, we have seen that about 23% of infant infections occurred as a result of mother getting infected after the initial HIV negative test. And in some estimates, this proportion is given as high as 40%, which means that this is an important group of women who require attention. And there are reasons why the risk of transmission among those women who acquire HIV, either during pregnancy or during breastfeeding, why they have a higher risk of transmitting to their infants. One is because with HIV infection, with acute HIV infection, the viral load is higher. The viral load is high at the point of infection. And at that point, there are no HIV immune responses. In addition, the intervention that we give to the mother or her infant, that is to provide them with ARVs, these women don't receive these drugs because they are not identified as HIV infected. Therefore, it's very important that as we move towards EMTCT, that we put in initiatives to promote primary HIV, so that we ensure that the HIV negative women remain uninfected, and we also contribute towards reduction of mother-to-child transmission. So the majority of women who come to the antenatal care or MCH test HIV negative. And we have to ask ourselves, what are the interventions that are available for them? For those women who test positive, we can start them on antiretroviral drugs. What about those who test negative? We have a range of interventions that they can be given to protect them and to support them to remain HIV uninfected. One would start with identifying the HIV status of their male partner, so that if the male partner is HIV infected, then the man is also referred for initiation of antiretroviral drugs, and the woman can be counseled to receive pre-exposure prophylaxis, which would reduce her risk of acquiring HIV during that time before the male partner gets to the point of virus suppression. The woman can also be encouraged to use condom in case they're in a discordant relationship or they do not know the status of their partner. The male partner can be counseled to go for the voluntary male medical circumcision, because male circumcision reduces the risk of HIV acquisition by almost two-thirds. And we would also be able to screen the women for sexually transmitted infection and provide treatment, because if we provide treatment, the risk of infection would also be substantially reduced. We'd also be able to offer risk reduction counseling. And depending, if the woman is at risk of HIV, can be offered pre-exposure prophylaxis, which could protect her and allow her to remain uninfected. So this assessment of male partner is very important. In the study that I detailed, we did an analysis of the sexual behavior and vaginal practices of those women. And we found that almost a third of these HIV negative women whom we were following prospectively for HIV incidents had partners of a non-HIV status. And we found that the majority of sex acts were unprotected. And we know in our settings, unprotected sexual act is the most common mode of HIV transmission. And you can see, while the frequency of sex acts and unprotected sex reduces as pregnancy progresses, we have a steady increase after delivery, which just goes to emphasize why it's so key to think of how to reach the male partner. So how do you reach the male partner? One of the ways has been to invite men to the clinics, but that has not been, has also its challenges, because our clinics, the way they are set up at the moment, they are not really very friendly. They are not male friendly. They are small, they are congested, and quite often men feel very uncomfortable going to that setting where they have to be surrounded by very many women. So in this study, we looked at offering of self-tests to the male partners, and we found that about 53% of the women whom we talked to were willing to take the self-tests, and they 93% offered the self-tests to their male partner, and they reported that in 95% of the cases, the male partner used the self-test kits, and actually in 99% of the cases, they actually tested, in 99% of the cases where the male partner used the test, they tested as a couple. I've dropped. Okay, another alternative, another way of getting to the male partners would be using home-based HIV testing. And in this study, again, conducted in collaboration with the University of Washington and University of Nairobi, we randomized pregnant women to either HOPE intervention or INVITE. And the HOPE intervention was home-based education and testing within 2 weeks of enrollment, or INVITE, where we gave written invitation for male partners to attend the clinic. And what we found was that if you look at all the parameters at 6 months, the proportion of male who are HIV tested was actually much higher. The female proportion of women who knew the HIV status of their partners was much higher, and testing as a couple was much higher. And also the number of serodiscordant couples who identified were also higher in the intervention arm compared to those who are in the control arm. We talked about male circumcision as a way of reducing the risk of men acquiring HIV. Clinical trials conducted in this country show up to 67% reduction. But again, this is data on male contraception rates, and again is based on the CANFIA. And we can see that overall, we have 91.7% of the male who are tested. But if you look at the counties which we highlighted earlier, which have the highest HIV prevalence, you find that the prevalence of male circumcision in those populations is much lower. So now we want to turn our attention to PrEP in MCH clinics, and the national launch of this program was in 2017. We can see Dr. Kioko doing the honors there. That was then. And we are going to also to present some of the results from the PRIA. The PRIA was a PrEP implementation in young women and adolescents. It was actually the first, to our knowledge, the first program evaluation of PrEP provision within the maternal child health clinic. And the aim was to provide evidence on delivering PrEP to women attending maternal child health clinics, because we believe that MCH clinics can be an important platform for PrEP delivery. As we have already shown earlier, incidence of HIV among pregnant women and breastfeeding women is high. And these women, majority of them come to MCH care, the MCH clinic to receive care. So that can be an important platform to receive them and to offer them interventions. In any case, most of the women, as you've seen, get tested within HIV, within the MCH clinics. We have very clear intervention for those who test positive. And among our intervention for those who test negative could be an offer of PrEP. So in that study, which was conducted in 16 facilities, we enrolled almost over 9,000 women, and we used a behavior risk tool, a risk assessment tool that was developed by NASCOP. And we found that 2030, which was about 21.7% of the women assessed initiated PrEP. However, we found that the follow-up was not very good because of those women who initiated, only 40% continued use after the first month, but not a complete loss, because even as we were offering PrEP to those women, some of them wanted to take PrEP because they had partners of unknown status, and they also took the self-tests. So for those who identified their partners to be uninfected, then probably they didn't need to continue PrEP. Also, as we've seen in an earlier slide, the frequency of sexual activity reduces over time. So some of the women may have opted not to continue using PrEP because they are no longer sexually active. The most frequent reasons we got for discontinuing PrEP was side effects, mainly nausea and vomiting, which we found were transient and would disappear, and the low HIV risk perception, which I've explained. But looking at who initiated PrEP, we found it was women who are less than 24 years, living with partners partner who was living with HIV, or partners of unknown status, those who came for ANC at an earlier gestation, those who had previously been diagnosed or treated for an STI, or forced to have sex, or experienced intimate partner violence in the past 6 months, were more likely to initiate PrEP. So as a way to promote retention and also continuation or continued PrEP use, we explored use of SMS messages among a subset of those women. And we had about 190 women who accepted, or who are eligible and accepted to be enrolled. And 99% of them reported that they received the SMS, and they also reported that these SMS helped them to better understand. The main issues that they raised were trying to better understand how you use PrEP, how does it work, what are some of its side effects. And we found that use of SMS increased the proportion of women who returned for their follow-up visit, and also the proportion of women who continued of using PrEP, showing that probably this is a possible intervention to promote adherence that requires further evaluation. We were learning how to offer PrEP in MCH at the same time we were offering. We kind of had to work with NASCOP to develop to adapt the training program which had been developed, but to better understand how to provide the counseling and information that is required, and also to see how well we are adhering to guidelines. We are currently, again, Kenyatta National Hospital, in collaboration with University of Washington, we are conducting a study, a cluster randomized study, to see whether standardized patient encounters improve quality of counseling for pre-exposure prophylaxis in adolescent girls and young women. This is a study that is ongoing. It will be in 24 clinics, and it will be a cluster randomized. So we'll have 12 clinics where we have this standardized patient encounter. We will go through training. Then thereafter, we'll have a training based on, for healthcare workers, based on lessons from based on the lessons from that interaction with the standardized patient. And therefore, we'll see whether when we have these kind of trainings, we have a better quality of counseling, we have better adherence to national guidelines, and whether we improve communication skills. We have already done the baseline assessment, and now we are on the second part of the intervention, where after training, we are going to go back and see whether this has made a difference. Also, again, Kenyatta National Hospital, in collaboration with the University of Washington, we have also been conducting another study to better understand the best model for optimizing PrEP implementation. And again, this is a cluster randomized study, and we have some clinics which are offering universal universal offer of PrEP, and another set of clinics where we have targeted PrEP offer, where the offer of PrEP is based on risk score and also partner self-HIV test. So we enrolled 4,500 women in 20 clinics, and we completed enrollment in July 2019, and the follow-up is ongoing. We expect to be done with the follow-up in December 2020. So in the next 2-3 months. So the other studies which are also in the process of implementation, we have PREPARE, which is PrEP in pregnancy, accelerating reach and efficiency. And the objective of this study is to improve integrated delivery of PrEP to women seeking health services in MCH and FP clinics, and translate implementation improvements into useful tools for policymakers and stakeholders. So this study will target healthcare workers, facility in charges, PrEP users, PrEP policymakers, and various groups of implementers. We also have another study, again, in collaboration with the University of Washington, Kenyatta National Hospital and University of Washington. And this one is aiming to systematically quantify infant pre and postnatal exposure to maternal PrEP, and to evaluate birth outcomes, bone growth, and urological outcomes following PrEP exposure. Although there are many studies which show that PrEP is safe, quite a large number of these studies are among women who used tenofovir for their care. They were HIV infected and they used tenofovir for their care. So we need to see, what about the women who are being given tenofovir as pre-exposure prophylaxis? So far, from the analysis we've done, from the program data that we have, there does not seem to be any cause for concern. But we want in this study to be able to follow up these women for up to 5 years, so that we can see not just the short-term outcomes, but also the longer-term outcomes. And also, we also have another study, again, Kenyatta National Hospital in collaboration with the University of Washington. And this one is seeking to optimize PrEP delivery for pregnant women, and here with a focus on using STI testing for chlamydia and gonorrhea testing. And again, this is just about to start. We have not started enrollment, but we have done all the regulatory. So this will be coming up. It will be a bit of time before we get the results. And lastly, we have another study which is trying to see ways of optimizing access to early antenatal care and pre-exposure prophylaxis among pregnant women. And this is trying to see whether pharmacies can be avenues for identifying pregnant women who are at risk for HIV acquisition and could benefit from PrEP. That is my presentation. I've presented some of the studies that we've conducted at Kenyatta National Hospital together with our collaborators, mainly University of Washington, University of Nairobi, Ministry of Health, and KEMRI, with support from CDC, NIH, and I also want to really acknowledge and pay my respects to all the study participants who have helped us to understand what has happened, the many program staff, study and program staff who have worked to collect the data, the support from the Ministry of Health, from NASCOP, the county governments of Kisumu, Siaya, Homa Bay, and all the study investigators. Thank you. I think after this, Dr. Bosire, you could give Jonah an opportunity to address the issues of DTG optimization before we take questions.
Thank you very much, Dr. Kinuthia. Yes, indeed. I would like to call upon Dr. Onentia to come on, maybe just make a comment in terms of programmatic gaps and maybe what is being done to address that. And then maybe you can also comment about the DTG use. Welcome, Dr. Onentia.
Good afternoon, team. Thank you, Dr. Kinuthia, for the opportunity. And indeed, the goal of EMTCT is actually elimination of both MTCT of HIV and syphilis. And the current MTCT rate, as you've highly mentioned, it is 10.8%. And we hope to reduce this to less than 5%. And among the strategies we are employing as a program includes male partner involvement, that is the testing, male circumcision, and secondly, also promoting the condom use and optimization, and also conducting advocacy. That is for early initiation of ANC, and it is out of that early initiation of ANC where we can be able to get our clients and be able to test them. And also the use of mentor mothers to enhance retention on care. And also, thirdly, optimization. And when we talk of optimization, we are, as a program, we are in the process of optimizing ART for women of childbearing potential from TLE to TLD. And because TLD has been proven to be highly effective in viral load suppression, hence it will be able to reduce our MTCT rate from 10.8% to less than 5%. So as a program, that is what we are currently doing. And of course, that one is ongoing, though we have already initiated or sent out circulars. At the moment, we are doing it on patient-centered approach. That is, you give the client the information they need, and then they make the choice, and we are able to give them the TLD. And we are also on the process of recalling. For those who are on TLEs, we are recalling them so that they can bring back the TLE, so that we can give them TLD, the regimen containing dolutegravir DTG. I think for now, that is what I can mention or add to the wonderful presentation that we've done. Thank you so much. Over
Thank
to
you very much. Yes, thank you very much, Dr. Onentia. And maybe I'll bring you back on, but let's go to some of the questions that have already been asked. I think
sorry to interrupt you before you
yes.
ask the question. Professor Ndwati is on, and you know she has really played a very key role in PMTCT in this country. So you probably could give her a minute or two to say.
Yes, sure.
Yes.
Prof. Ndwati.
Yes, thank you very much, Dr. Kinothia. That is such an excellent presentation. I think the only thing we can say, and which we probably should discuss on a different day, is prevention of mother-child transmission of HIV in the baby who is breastfeeding. I think we're looking at that and seeing what are the challenges and opportunities that there are. The particularly supporting exclusive breastfeeding, and how do you maintain that momentum for the mothers so that that they really are very suppressed until their baby is fully weaned. But I think you've really done an excellent job. I want to congratulate KNH for really distinguishing itself as a leader in this area of research. This is excellent. We're proud of you.
Thank you, Prof.
Thank you, Prof. And maybe Dr. Kinothia, you can comment, and then we go into the other questions. I noticed from your presentation that we have, since 2017, we have not been able to go back even to the close to the 8% transmission rate that we had before. And now we are in 2020 and COVID has happened. What do you think is the reason why we are not even able to go to 8% and even continue to make progress in terms of that? And how could that be contributing to current MTCT rates, or what is happening right now? Even though we don't have the data, what do you think could be going on now in the face of COVID-19?
Yeah, thank you, Dr. Bosire. I am wondering whether Dr. Onentia will not be probably the best person to say what he thinks. You know, he's a PMTCT boss. He's our boss in that field.
Right, Dr. Onentia.
Let me put you on the spot. Okay. All right. We don't seem to have him. I could speculate, and I would say that I think there is a challenge with these there may be a challenge with the way that disruption. I think always when there is a disruption, there is always a bit of time before things really go back to the way they were. And you find that when you have a disruption, it interferes with the smooth operation. I think that played a role. Another role which another act which I think played a role, and I know Prof. Ndwati always raises this and believes is the most important, is this issue of testing. That we had a system whereby the nurses in the MCH clinics would be able to offer testing. Then this was taken to court. One of the staff was taken to court, and the court seemed to rule that it's only the laboratory technologists who would do that. And I think that was unfortunate. And I think what we have heard is that there are ways the ministry has been working, and that's why I would have wanted Jonah to comment on this, so that that ruling is changed, so that there is ability to ability to allow that the providers within MCH can provide testing. I would also probably want to hear from Prof what you think besides the testing could be any other role that you think could be playing a role in our rates.
Thank you, Dr. Kinuthia. You really have raised the issue. I think the other thing that has happened last year and less so this year is that we had an unstable supply of drugs. There were many times when facilities reported they didn't have, particularly the infant prophylactic medications. And so if you don't provide the ARV prophylaxis, then you're not able to actually prevent transmission. There's also another practice. The core staff, the core professional in the MCH is the nurse. The nurse midwife is actually a very valuable professional in the healthcare system, and particularly in this area of mother-child transmission, preventing mother-child transmission of HIV and the whole pregnancy and child health-related issues. However, there's a practice of shuffling nurses around. After so many months or year, or maybe a year or two, they're moved to a different area. Now, this practice is actually bad because there's loss of institutional memory. Every time people move and you have a new cohort coming in, they have to almost learn from scratch what system works in this place. The way the client flows in the MCH, whether people come from point A to go to point and then go to B, C, or whether they go to C, D, makes a difference in terms of uptake, particularly of the testing, and of course then the delivery of the intervention. So if we were to reach a point where we recognize the nurse midwife as a professional, as a specialist, like other countries have done, for example, the nation of Mozambique considers the MCH nurse is a specialist, and that you don't keep shuffling them around to go and do other things, they stay in that area. I think we could definitely improve the quality of services that we provide, both to the mother and the child, and definitely in this area of PMTCT. I think the other problem we have is this constant industrial disputes between the health workers and their employers, and in this case, the county governments. It's every time there's a strike, there's a cohort of mothers who will go through their pregnancy. Pregnancy is like pregnancy is like an electric train that is moving. It will move whether you are there or not. And so for that cohort that goes through and misses the interventions at the time it was supposed to happen, is a cohort of women who are going to have increased likelihood of transmitting to their children. Even if the women were negative, as Dr. Kinuthia showed, that the majority of women in ANC are negative, they will have missed the important health education. They have missed the opportunity to bring their partners for testing. In the large studies done, 40% of individuals who are HIV infected were in a long-term relationship with somebody who is not infected. So discordant couples driving a lot of our epidemic. So if you came through and nobody talked to you, or the facility was shut, if the facility is shut and today was your expected day of delivery, you still deliver. So I think there's a great need to focus on how we can stabilize the health sector, stabilize the service provision, deal with this, minimize this constant human resource for health struggles that are within the service. And again, the recognizing the MCH, the nurse is the best professional in the MCH, and she's capable of testing. And these tests which are called point of care tests are supposed to be done by the person who's actually providing that service. Thank you.
Thank you very much for that. Dr. Onentia, did you want to comment anything? I see you're still on.
I think we have actually, Dr. Kinuthia and Prof. Ndwati have actually captured all the concerns. But I want to look at, there's a question that was asked at the chat box concerning about a high prevalence of
I may disappear.
I think we've lost you, Dr.
Yes, there's a high chance of low uptake or dropout of ART during the postnatal period. And this is because of there is a loss to follow-up, especially between 6 weeks to 6 months. And there are usually high chances of new infection, especially around that time. And also during that time, we have low testing of the mothers. And this is also attributed to what has already been alluded to, that already there is a court case on who is supposed to do the testing. Our take is as a program that if we can be able to strengthen the MNCH so that our midwives can be able to undertake or do those activities, then we will not be having the setbacks that we are getting. Because one of the reasons of the MTCT rate going up is because if we cannot be able to detect or get the clients during the testing period, then we completely lose it. We cannot be able to do the testing, so we cannot be able to identify. And at the end of the period, we come to realize that we have high MTCT rates. So that court case of the lab and the personnel who was taken to court, it has really affected the program very much. And there is also, during the postnatal period, as I've said, there are usually high rates of infection during that time. And also, the other thing that I would like to respond to is that there was also a question that was asked on the data or the impact of COVID-19. As a response is that we have not personally looked at the available research or evidence on the impact that has had on the program. But in our section or through Siri, the data section, we are currently planning to do as a research subject the impact of COVID-19 on the PMTCT. Then we will be able to have data as a program. I think for now, that is what I have to add to what Prof. Ndwati and Dr. Kinuthia have said. Thank you.
Dr. Kinuthia, maybe you can take a time and enable Professor Ndavi to make a comment, and then we also can get to somebody. If you're able to do it just now, then he can make a comment.
Yes, it's being done right now.
All right.
Yes.
As he comes on, maybe before he comes on, Dr. Kinuthia, would you like to comment in terms of the SMS and its ability to improve adherence? What do you think is the reason that resulted in improvement in adherence? Is it that the women felt more supported? Is it that they had forgotten to come to clinic? What do you think was the reason why SMS improved adherence? And I can see that you've gone ahead to want to roll that out further and expand its use within the settings, clinic settings.
Okay, I think use of SMS provides an opportunity to provide the women with more information, and it also allows for a bit of back and forth where somebody can ask, so what would happen if I do this? Then they get a response. What would happen if I do this? So they get a bit more educated. And we believe
Sorry, we've lost you, Dr.
Rose, maybe I can comment as we look for Kinuthia.
Yes.
That actually the SMS is phenomenal. We've used it in, we've had some, I think now 3 studies by residents in pediatrics looking at this general area. One we randomized to actually a phone call versus standard of practice to see whether we could improve breastfeeding practice, exclusive breastfeeding, and particularly in the context of HIV. The other was, that was by Ruth Kihara. The other was a study in Kisumu to see whether we could actually improve infant prophylaxis and again, adherence to clinic visits and adherence to the ARVs. And the most recent one was looking at whether we could improve the postnatal follow-up. You know, that 6-week visit where many mothers don't show up. And in all of them, the use of the SMS or phone call increased uptake, increased adherence or uptake to more than 95%. And in this last study where they were looking at postnatal visit, the women report that they feel wanted, they feel that the healthcare staff care about their outcome and about their children. So it actually increases motivation for use of the health facilities and the health services. Thank you. I think Dr. Kinuthi is back.
Okay.
Sorry, my internet dropped and I didn't realize, so I was speaking to myself. So I didn't hear most of what Prof said, but I know she talked of some results which have shown some benefits. I can also add that for us, we believe that the SMS allowed for women to get more information about PrEP, to be able to ask more, to learn more about what is PrEP, how does it work, and this was particularly attractive probably for those women who felt not very comfortable talking to the provider one-on-one. But when they are able to use the anonymity of SMS, they were able to raise those issues and concerns. And once they were addressed, they were able to feel more comfortable to use them. It's also possible that in addition, the reminders also helped. Yes.
Thanks a lot, Dr. And I want to ask Professor Ndavi to comment. Professor Ndavi, you're still muted.
Now, can you hear me?
Yes, now we can. Thank you.
Oh, you can hear me?
Yes.
Very good. Good afternoon, everyone. Thank you, Ross. Thank you, Ruth. Thank you, John. Thank you, Jonah. I have been struggling for a very long time trying to join your webinars. I finally managed to do it today, and I'm grateful. Now, I want to thank the team because you are using evidence-based approaches, and it's very exciting. And now, because I have stolen a few ideas from you, let me pay back by also sharing.
Yeah.
Yes, John.
Yes.
Let me confess stealing ideas now for other programs in sexual reproductive health. On the number of the issues that Rose raised, that by 2017 reached a figure of about 8, and now it doesn't seem to be obtaining anymore. One, we need to look at the issue of saturation. We need to look at the numbers of the relevant healthcare providers in the area of EMTCT. Professor Ruth did mention something about the counties and the issue of industrial stripes. But we must also recognize that counties have to rely on national appropriation for everything, including human resource. We know, first of all, there's a crunch, and the numbers of the appropriate relevant healthcare providers who need to address the issue of promoting prevention or elimination of mother-to-child transmission, that number doesn't seem to increase. Does it mean the number of pregnancies are going down? like she said, it's like a train that has left the railway station. It will go. So that is one area. When you look at these issues, you need to have a serious conversation with, as a program, with the counties. The midwives numbers are not increasing. Secondly, if we want also to build the capacity of that relevant workforce, and as Ruth has mentioned, the nurse or the midwife in those facilities. Yes.
I think we've lost Prof. Sorry, Prof, we cannot hear you. Are you still there? Maybe while he figures, I think we've lost him. Maybe while he's trying to come back. Dr. Kinuthia, do you want to comment on the question that Dr. Bukusi has asked about collecting our own data and findings on the missed testing opportunities at KNH and other PMTCT centers as a foundation for seeking review of the court ruling on the limitations in testing in the clinics, or might this already have been done?
Sorry, I didn't get the question very clearly.
The question is about collecting data that would help, maybe rather than, like, for example, asking Dr. Nentia to go to court and say, no, we need to reverse that. Do we have data that we can maybe present to the court that would help reverse that decision? So Dr. Bukusi is asking whether we can collect data from KNH about the missed testing opportunities and other PMTCT centers so
Yes.
that that court ruling can be reviewed.
To my knowledge, I don't know whether anybody has done that, and definitely we could work with Dr. Bukusi to try and collect that information. But again, it depends on whether Jonah and the Ministry of Health we believe this could be useful. Yes.
Thank you. Professor Ndavi, are you back now? Not yet. So maybe, I don't know, maybe while he's coming.
Rose,
yes?
let Dr. David speak. I think you might hear him. Patrick, just talk. Talk loudly, they'll hear from my connection.
It's very distant.
And I like what the interventions that are going on is further looking at the issue of person-centered communication and building the nurse midwife so that the person-centered communication strategy. One, we build their self-efficacy, and that self-efficacy further increases their motivation to deliver the service. Now, part of this person-centered communication, so that their communication with our level client. And I'm happy that also looping in their male partner, which is very good. So that our nurse and nurse midwife have that, competence in executing the person-centered communication. We are trying a manual of person-centered communication. We call it the ABCD. With which it goes A stands for address and access, B is about need, C is about change, and the D is about vision. My power come, but I'll see whether I can get back on my phone.
Okay.
That again is the saturation with the numbers of that midwives. If they are now taken to yeah. That's right. Whether that again will begin to
Yeah. Okay. Thank you. I think they have had. Rose, you have had.
It was very faint. Do you mind just recapping very briefly what he said? Because he was very...
Are you able to get back onto it? Yes. Let me recap for them. Dr. Ndavi has talked about the importance of communication, building the self-efficacy of the midwives on communication, the focus being on patient-centered communication or person-centered communication. So better skills, and they are developing a manual to support that. And he's of the opinion that even given the problems we have, this may provide an opportunity for improving the delivery of services within the circumstances that they are. But he does also emphasize that there's a need to relook at the establishment of nurse midwives at county, and then there's a real need to actually increase the numbers. I think Patrick have captured that. Okay, he owes me. I'll take it for Nyamachoma. Okay,
right, thanks a lot. Maybe I would want also Dr. Nentia to comment just very briefly. I noticed that a lot of the steps that you are taking to try and close the gaps revolve a lot around either the provider or the client themselves. And I just wondered, or even just about the treatment itself, like efficacy, using a drug that is more efficacious. And I just wondered whether you have any comment to make about system challenges or system bottlenecks, because I can see when people are still commenting about issues around supplies of either test kits for STIs or the infant PMTCT regimen. So is there anything that maybe is being done, or are we maxed out on what we can do to improve that?
Let me add to that question. Where is the discussion about shifting some of this procurement to UNICEF? Because I think the problem is KEMSA.
Unfortunately, I realized that I think Dr. Nentia might have dropped off. I don't see him.
Yeah, he does.
Pardon?
I think he may have dropped off.
Yeah, I think unfortunately he dropped off, but maybe I think we can bring him back some other time, and also maybe bring him together with Dr. Ndavi to talk a bit more about this issue, because I think system challenges are a big problem. And
yes.
Maybe, yeah, without addressing those, perhaps we can bring in the best regimen, we can come up with the best protocol, but still we need the system to work for the interventions to reach the mother. So for them to actually also be delivered effectively.
Yes, I agree with you. I think that seems to be an appropriate approach. Definitely, the empowerment of healthcare workers is important. How we communicate is important in terms of whether the interventions we are advocating for are taken up or not. So I think your suggestion that we should also look for another opportunity to listen to Professor Ndavi, where he can explain these issues in more detail, would be a good option, a good way.
Thank you very much. And I see that we are like 3 minutes or past the time. So I want to thank all the participants. You're all very active participants. Thank you for coming. And also thank you, Dr. Kinuthia, for that wonderful presentation. Also for Dr. Onentia, Prof. Nduati, and Professor Ndavi for your contributions. And we hope to see you again. Thanks a lot, everyone.
Thank you.
Okay, thank you, Rose.